Good morning, everyone. My name is Dr. Hiranaka from Japan, Osaka. I am actually working in the hospital in Takatsuki. It's very between the Kyoto and Osaka. They are very famous tourist spot. So if you came to my hospital, you can access easily to Kyoto and Osaka. It's very nice place. This is our team. Our team is only 8 members in the orthopedic department. Every doctor have the specialty, such as hip surgeon and spinal surgeon. I'm the chief of knee department. Anyway, I heard that this is I might be a first speaker of this new conference room. This is the first congress. It's a brand new building. I'm very honored to speak to you. This meeting, I think, focused on kinematic alignment total knee. So in fact, my specialty is UKA as well. So because to understand the UKA is very important, because concept of UKA and kinematic alignment is quite similar. So once I do the TKA using mechanical alignment, I'm very disappointed to do the TKA because concept is quite different between the UKA and mechanical alignment TKA. So then I moved to the kinematic alignment TKA. The concept is very similar. So I use the same concept, same policy to do both UKA and TKA. So it is very valuable to understand what is the concept of UKA and how to do the UKA for your future. This is the third time to came to Vietnam for me. 3 years ago, before the COVID-19 spreading, I came to Hanoi and Ho Chi Minh. And in Ho Chi Minh, I did the live surgery. But in this time, I did TKA using mechanical alignment. Just after that, I moved to the kinematic alignment. Anyway, this is the simple concept of UKA. The concept is resurfacing. And through intra-articular operation, we never manipulate the total alignment. So the aim of UKA is to restore pre-disease condition. This is quite a similar concept to the kinematic alignment. So if the patient have constitutional native villus alignment, just restore the patient native alignment. That's all. Never reconstruct the patient alignment to be neutral. So we should accept constitutional villus because most patients, especially in the Asian countries, have constitutional villus. So the aim of UKA just restore normal length and tension of MCL to makes good alignment, such as neutral alignment. We need to release MCL, but in UKA, we never release MCL to adjust the total leg alignment. So instead, we should accept villus alignment postoperatively. So this is another concept of UKA. I've always used mobile bearing UKA. So mobile bearing is replicate the function of meniscus. In our knee, so meniscus can change its shape and its location according to the movement or relationship between femur and tibia. In extension, the thickness is thinner and width is wider and locates anteriorly on the tibia plateau. In the flexion, move to the posteriorly and thicker and narrower. So, but using artificial material, this function cannot be restored. So instead of change of shape of the meniscus, in the mobile bearing, changed the shape of femur to be spare, like this. So this is very, very innovative. This mobile bearing is have been used more than 50 years. We can still use this concept continuously. So relationship between femur and bearing articulates like total hip, boring socket articulation, and based on bearing in the flat, it articulates with flat tibial surface. So there is fully, we call it fully congruent and non-constrained articulation. The benefit is minor malalignment can be accepted. So we plus minus 5 degrees can be accepted because some minor alignment can be accepted due to the perfect articulation between metal components and bearing. In fact, the wear is quite small, less than 0.01 millimeter per year. It is quite different from the fixed bearing, UKA. And there is virtually no revision cost in terms of mobile bearing UKA. On the other hand, around 12% of revision case is reported to be due to the wear of polyethylene. So this is the principle of mobile bearing, fully congruent, non-constrained, and wear and acceptable alignment. But we need to adjust the gap in the flexion and the extension to prevent the dislocation of the mobile bearing. Because mobile bearing not be fixed, only move between the tibia and the femur components. This is the indication of UKA. The full thickness cartilage wear on the medial compartment or lateral component, and normal lateral or opposite condyle cartilage, and intact ACL, or osteonecrosis. There are the two big indications for the UKA. And the pain and function will continue more than 6 months or despite of conservative treatment. So this is a decision matrix of the knee osteoarthritis in terms of ACL integrity and lateral cartilage condition. ACL intact or not. Lateral cartilage is intact or not. So we can have the matrix. So for the UKA, in the indication is intact ACL and intact lateral condyle. It's quite simple. But in our patients, this category includes around 60% of patients. But in fact, only 10% or less have the UKA in such patients, or because some restriction of reduction by the surgeon or indication, understanding of the indication can reduce this usage of UKA. The first one, the surgeon preference. UKA, the revision rate is referred to be around 2 times higher than TKA by the national registration. But in terms of Oxford mobile bearing UKA, 20 years survival rate is reported to be the 91%, and another quote around 90% in the 50 years survival rate. It's quite good. But what is the difference? The difference should be the familiarity or the patient, surgeon experience. This is a national registry data. If we do the 58 cases annually, the revision rate reduced dramatically. And percentage of usage of UKA is also important. If we do the UKA, around 40 to 60% in the all candidates to the knee arthroplasty can achieve the least revision rate. So if you do the less than 20%, that means the lack of skill. Experience is not enough. And more than 80% means over-indication. So experience is very important to do, especially in the mobile bearing UK. I visited to the Oxford, that is a designer's hospital in the UK. I learned a lot about mobile bearing UK. That was very good experience. I stayed in Oxford long for 6 months. That was amazing experience. So I mastered this operation perfectly. Then I go back to Japan. So far, my average rate of UKA is 6% in all years. But you can have another chance to learn about UKA, of course, about kinematic and limatic, because our hospital is authorized training hospital for the foreign doctors. So if you come to my hospital, we can provide a temporary license, medical license, so you can join the operation. And even you can do the surgery in my hospital under my supervision. Then after the fellowship, you can get the official license, official certification from my hospital and from my government as well. It can be very useful if you build up your career. So if you're interested in this system, please inform me. Anyway, the first one, the surgeon familiarity or preference or experience. Another one is restriction. If the patient have the intact ACL and intact lateral cartilage, some restrictions such as overweight and young age and very active, so chondrocalcinosis or patellofemoral arthritis, and flexion contracture and varus alignment or lateral osteophytes can limit the usage of the UKA. This is reported by Cousin and Scott. It's a very classical contraindication. But if you apply their Cousin's contraindication, the percentage of UKA reduced around 10% or less. In fact, in the most registry rate data, is reported to be the usage of UKA around 8% to 10%. But using the Oxford criteria is a simple indication. around 50% can be a candidate for UK, at least Oxford mobile bearing UKA. So this is a decision aid using the simple X-ray, stress X-ray and weight bearing X-ray in the medial side bone and functional intact ACL and on the lateral X-ray and the intact lateral cartilage and correctable varus alignment. So you can get this one from the internet, from the Zimbabwe homepage. It's quite simple and very useful. If we follow this criteria, is good clinical outcome can be achieved. Even more, this is the report to the contraindication with the contraindication by causing with or without the contraindication. There is no difference between contraindication or with contraindication or without contraindication. There is no difference, and even better clinical outcome. The patient with contraindication reported by causing. This survival rate is similar between the patient with contraindication and without contraindication. So in the field of Oxford mobile bearing UKA, those causes contraindication such as high weight, high activity, or younger age doesn't matter. In fact, I do the UKA for the 40 years, 50 years, or that might be the indication for the high tibial osteotomy. I do not hesitate to do the UKA because UKA can achieve the quick recovery and the perfect leg alignment and the perfect patient activity. So using this system, or maybe how patient can be applied the UKA. This is another matrix. This is ACL deficient and lateral condyle intact cartilage. What to do? Maybe this can be the candidate for TKA. Of course, that is a natural. But because in the classic report, without ACL abnormality, can reduce the longevity of the UKA. But in fact, in previous report, or without the intact ACL can achieve the good midterm outcome. So if the patient doesn't have the intact ACL but intact lateral cartilage, in the high age patient, we can do the ACL, we can do the UKA to reduce the invasiveness of the operation for the elderly patient or high-risk patient. This is one option. So there is the two types of osteoarthritis in terms of ACL integrity. The first one is primary ACL deficiency, and the secondary osteoarthritis due to the anterior instability of the knee. And the second one, the primary OA and the secondary ACL deficiency. As you know, there is some osteophyte in the intercondylar notch can damage the ACL. In this patient, so due to the soft tissue contracture or osteophyte can prevent the anterior dislocation or subluxation. Keeping this situation is ACL is gradually damaged and finally torn. Then in this situation, the patient have the ACL functioning situation. So in this patient, I think we can apply the UKA for this patient. And in this patient, in the primary ACL deficient patient, of course, normally we should do the TKA. But instead of usage of TKA, we can do the UKA in the same time reconstruct ACL reconstruction. In some limited cases, the result is very good. Combining to the ACL reconstruction and the medial side of unicompartment arthroplasty. Another matrix is intact and ACL lateral conduct damage. Sometimes we experience these patients. Normally, we can do the TKA in this patient, but I'm very disappointed to the cut ACL during the surgery to do the TKA. Because I also, the arthroscopic surgery, I do the arthroscopic surgery such as ACL reconstruction. In the same day, I reconstruct the ACL in the morning. Then in the afternoon, I cut the ACL due to the TKA. This is very, very disappointing. So I want to retain the ACL as many as possible. This is an interesting paper. If the patient have the intact ACL at the surgery, TKA surgery, the clinical outcome is worse than the patient have the deficient ACL at the time of surgery. So if we cut ACL for the TKA, that can be a slightly decrease the patient outcome or satisfaction. Because I think the patient remember the situation of ACL impact of the knee. So how to prevent ACL? One solution is BCR, by cruciate retaining TKA. I tried this one, but if we retain both ACL and CCL, the morphology of articular surface should be the completely same of the patient native situation. This is a very famous the pore linkage model. If we decide soft tissue, like this ACL, the morphology is completely decided by the situation of the surrounding soft tissue. So surrounding soft tissue decide the morphology of the articular surface. If the morphology after the TKA is perfectly matched to the patient original the articular surface, the outcome result should be perfect. So after the BCR, some patient in the perfect situation, no pain, the full range of motion, but after the TKA, the morphology is not quite different from the patient original one. Some conflict between the original morphology and replace articular surface can make the confliction and make stiffness or pain. So how to, yes, so after the operation, this morphology should be same. But if we cut the ACL for such as PS or CL components, some laxity can be given for the knee. So the laxity can accept some difference of morphology before and after the operation. To solve this problem, I started to do the bilateral unicompartment arthroplasty. In this approach, we can make the medial side perfectly, then move on to the lateral side perfectly. That's right. Then the last one is ACL deficient and lateral condyle deficient. This is a true indication for the TKA. This patient, I prefer to do the kinematic alignment, but in the near future, in recently, there are so many types of kinematic alignment. So I summarize these concepts, these approaches as personalized alignment TKA that aim to the patient own alignment, speaking the patient own alignment. So anyway, I will talk about personal alignment in my second talk. Anyway, the UKA is a kind of personalized alignment, aiming the patient own alignment and the patient own situation. So even for the TKA, I aim to the similar concept to the UKA and this personalized alignment or kinematic alignment TKA, because this approach respects patient own situation such as alignment, leg alignment, morphology, and soft tissue balances. So then I move on to the kinematic alignment UKA. This is so too specialized, so I skip these statements anyway. So this is the step of kinematic alignment UKA. But anyway, so that time is limited. I skip this statement. Anyway, this is the take-home message. There are 4 types of arthroplasty situation. One is the ACL intact and the lateral cartilage intact. That is definitely indication of UKA. But most of contrary indication can be ignored in terms of the Oxford UKA. And if ACL deficient with the lateral cartilage intact, it can be possible to do the UKA in limited situation. And ACL intact but lateral cartilage damaged, we can do the TKA. Basically, TKA can be do, but by UK and BCR is challenging operation to retain the ACL. And ACL and lateral cartilage damaged, we can do the TKA, but move from the mechanical alignment to the kinematic alignment or personalized alignment, TKA. This is the end of my talk. Thank you for your attention.
You finish your talk here, or?
Oh, so later I have to modify my friend.
Yeah, I will do a short translation to the audience. Mọi người cần phải hỏi gì không ạ? Question for you. Okay.
Hi, good morning.
Good morning.
So I agree the concept of kinematic alignment when we do UKA, because we restore the volume of the joint. I don't like to use kinematic alignment when we do total knee arthroplasty, because we are changing completely original kinematic. In fact, you are speaking about the personal alignment. In my experience with the UKA, I had the opportunity to study by navigation system, open navigation system, different unicompartmental. And the problem that was common to all the unicompartmental was the problem of the rotation. Because especially in various knee, we know that the center of a translation that people shift is in the middle side. We lose this control of the middle side. So I see that you use mobile, Oxford, UK. Did you see if the kinematic, because I had the opportunity with navigation, I don't know if you had this, that the rotation is completely different from the original?
No, I didn't analyze the rotation of the after UK, but previous report, my friend analyzes the kinematics after the Oxford UK. The kinematics is quite similar to the normal knee, and after the Oxford knee compartment replacement. So I believe if we retain the ACL and other soft tissue situation, the kinematic it should be similar after the Oxford UK, including the rotation of the tibia around the femur. And more importantly, in the Oxford knee, the relationship between the tibia component and bearing is very important because the bearing is far from the tibial lateral vertical wall of the tibia component. The mobile bearing can spin. The spinning of the bearing can induce the bearing dislocation. So we are very, very sensitive about the alignment of the rotational alignment of tibia component to prevent the dislocation. But I believe the kinematics, including the rotation of the tibia, it can be similar to the normal knee after the mobile bearing Oxford UK.
Okay.
So I have one question for you.
Yeah.
So according to what I know, the biomechanic of the knee is from 0 to 120 degree of flexion. The medial side, there's no rollback of the medial condylar over the tibia. So why you keep doing mobile bearing for the medial side?
Medial mobile bearing, the movement is completely moved passively. The relation between the femur and the tibia component. I analyze the movement of the mobile bearing of the tibia tray. In fact, it moves posteriorly around 8 millimeter in average, especially after the 90 degrees in flexion. So that's maybe that can due to the one reason is morphology of the femur components. The femur component is completely sphere, part of a sphere. So this is something different from the original morphology. Also, contact point can be changed if we change the shape of the femur component. That is the one reason. But in fact, so there is no restriction, no control in terms of mobile bearing movement in the mobile bearing. But in fact, so the movement of a mobile bearing very stabilized.
Very
Stabilized, very stable, as long as the gap balance is proper in flexion and extension. So you can't imagine if you don't have experience of Oxford bearings, but once you experience Oxford mobile bearings, so bearing movement is very stabilized as long as gap balancing is proper. So that I believe that can mimic the original movement of medial femoral condyle on the tibial side.
Câu hỏi không biết mọi người có để ý nhưng mà lúc đầu ông giới thiệu thì ông có đưa một cái slide mà mình thấy cái MRI khi mình chụp cái MRI ngắn ngoài của gối á, bệnh từ lúc mà gấp thì cái hình dạng của cái súng chém ngoài và cái hình dạng cũng như là vị trí của nó sẽ thay đổi. Khi mình gấp là súng chém nó sẽ đi lùi sau và nó hẹp, nó co lại. Thì đó là cái điều mà ông lý giải cho việc là sử dụng mobile bearing cho thay gối một ngắn. Nhưng mà về mặt sinh cơ học á, thì cái ngắn trong nó lại không có như ngắn ngoài như vậy. Thì câu hỏi của mình là vì sao lại vẫn dùng mobile bearing cho ngắn trong? Thì nói chung
But in terms of sagittal movement, anterior posterior movement can reproduce the normal kinematics. But current technique, that we cut the tibia perpendicular to the tibia axis. But in fact, medial tibia plateau is slightly inclined medially. But we cut the different angulation in terms of the coronal alignment of tibia. So maybe that can cause some conflict or some difference between the normal kinematics and after operated kinematics in terms of coronal alignment kinematics. So I changed to the cut the tibia parallel to the tibia, medial tibia plateau to replicate the perfectly the both sagittal and coronal movement of a mobile bearing on the tibia triad. So that is the kinematic alignment unicomponent arthroplasty.
Thì câu trả lời lúc này của ông thì thú thật là mình nghe mình cũng không hiểu hết. Nhưng mà ông nói ông làm nghiên cứu thì ông thấy khi mà mình gấp thì cái ngắn trong nó có, thực ra cái chuyển động của mobile bearing là chuyển động thụ động, nó sẽ ông làm nghiên cứu ông thấy nó có gấp. Khi gấp thì nó vẫn trượt khoảng 6-7 ly, hồi nãy ông nói 6-7 ly thì vẫn mô phỏng lại được cái chuyển động học bình thường của gối. Thực sự là mình không hiểu lắm cái câu trả lời của ông.
A question. When, because you show sometimes you do B uni.
Yeah. Yes.
Okay.
This
So,
one.
yes, when you do B uni, how you calculate the weight bearing on the other side? So you do 50% of weight bearing, or you prefer to overcharge the medial or lateral? So how you calculate when you do B uni?
There is no way to calculate the weight bearing. It just replicates the ordinary articular surface using the component. In the most case, the start from the unicomponent of arthroplasty, I prepared back up lateral side UKA. Interoperatively, if I find the intact ACL and lateral cartilage damage, I've changed to the bilateral UK. But in the previous report, a very, very classic report, if we implant the total knee using the one-piece tibia component, if the load is concentrated to the medial side, lateral side it can be lifted up due to the one-piece component. But if we implant both sides, so lateral side never lift up. That is the benefit of the bi-unicomponent arthroplasty. But in fact, this technique is quite difficult. It's very complex. The problem is the operation technique, the operation accuracy, rather than the weight bearing. So I'm improving how to do this technique easily and reproducibility. I have now devising the new custom instrument to do this operation more reliably.
Mm-hmm. So you don't use some skill specific instrument for the soft tissue balancing?
No, yes, only the feeling of the pillar gauge,
Okay.
one kind of the spacer.
Mm-hmm. Okay, thank you.
Mọi người có câu hỏi gì nữa không ạ? Trí?
Hello. How do you know the ACL enough tension when you do BUKA? Because maybe more tension is pain. If you lose, maybe fail.
Also, we can reconstruct the patient's soft tissue. We can reconstruct the patient's soft tissue balancing step by step. The first three go implant media side UKA. Because Oxford G is perfectly respect the patient, perfectly respect patient soft tissue balancing. So bone cut and the bearing thickness is decided by soft tissue balancing. So after the mobile bearing UKA, soft tissue balancing can be perfect. Because this is the aim of this procedure. Then move on to the lateral side. After the perfectly reconstructed medial side situation, then move on to the lateral side. The lateral side is slightly different to the medial side. The aim on lateral side is restore the perfect balancing only in extension. Because we can accept the lateral side looseness in flexion. Because in most knees, lateral gap is looser in the medial side in flexion. But in the extension, so medial and lateral balancing should be perfect. Then medial side, complete the medial side and make the perfect ligament balancing, then move on to the lateral side. Finally, balancing should be perfect. Thank you very much.
Thank you for your amazing talk.